Hope everybody is having a good week so far. It's Wednesday. Um, so we're gearing up for exam two. So for today, we have chapters 8, 9, and 14. Um, Before we get started, um, just want to, does anybody need anything? Does anybody have any questions? Everybody good with the group project? So I figured I'd just throw that out there. No questions, no issues.
Group
Yep.
project.
What about it, hon?
How many? I'm guessing this is going to be PowerPoint.
It is. It is a PowerPoint slide. So I'll pull up the project and I'll share my screen real quick. All right, so you've got your time. Everybody has got their assigned. Well, there's only two groups. I assigned the two topics. And so yes, whatever your topic is, it says poster, we know, but that's just not effective and online. So we decided a PowerPoint would be fine. Um, the slides is up to you, however many slides that you need to get to have all the information that you need to present. And so just, whatever topic is, like I'm just going to use PN in the nursing process just as an example. So compare what a task focused day looks like versus where the PN uses clinical judgment and clinical thinking, and then highlight how practical nurses can go beyond routine tasks by thinking through patient needs, priorities, and safe care planning. So however many slides you need to do that. Make sure that you have a title slide, right? So your title slide, however many slides you need, and then a reference slide. So you will need to put your references on that last slide. Um, and make it engaging, make it pretty, like colors, you can use graphics, you can use pictures, whatever it is that you want to put in there. And just remember, again, it's only two groups, but just remember that everyone has to participate. I don't know why my camera is like just showing the top part of my face. Um, the chair is up as high as it can go. Um, just remember that everybody needs to participate, everybody needs to present some part of it throughout the presentation, but really there's no set number of slides. You guys just, whatever you guys feel is um, effective to share to get the information presented. The only other thing too that I want everybody to remember is everybody has to submit the final presentation in their Canvas, okay? So I know that everybody's, you guys are split up in two groups. That's great. But everybody has to submit the final presentation. So if there's one person that's putting the presentation together, make sure that all members of the team have the presentation so that everybody can put it into Canvas. Okay. Because it's the only way I can grade it and show that you guys submit it is by having it there. Right. So if somebody were to come back and audit and be like, well, this person didn't turn anything in. How did they have a grade? You have to have something in there. Does that answer your question, Victor? Okay, good. All right. Any other questions? No. All right. So again, we're going to talk about what is it? It's communication, assertiveness, and then chapter 14 is the interdisciplinary care team. So communication, we're going to start with communication. We know how important communication is in healthcare, okay? We have to be able to communicate with our clients. We need to be able to communicate with fellow nurses and other members of the healthcare team. We have to be able to do this effectively to get our points across as well as to give information, right? So we're going to start. I have a little exercise. And if you've gone through the slides for this week's readings, you've probably already seen it. So I will share my screen. All right. So here we have Maria Lopez is a 68-year-old patient. She was admitted to the med surg unit with pneumonia. She has a history of hypertension and type 2 diabetes. Maria primarily speaks English, I'm sorry, speaks Spanish and understands only limited English. Her daughter usually helps translate, but she is not present during the morning shift. The LPN assigned to Maria, Jamie, enters the room to administer medications and perform a respiratory assessment. Jamie explains the medication quickly in English while preparing them. Maria appears confused but nods her head. During the assessment, Maria repeatedly points to her chest and says something in Spanish. Jamie assumes Maria is referring to the pneumonia and continues the medication administration. Later, the RN enters the room and uses a certified interpreter. The interpreter learns that Maria has been experiencing new chest pressure and dizziness for the past 30 minutes. The RN immediately notifies the provider and initiates further evaluation for possible cardiac complications. All right, so let's see. So let's start with what communication barriers were present. So, what were some of the barriers that we had in this scenario that were present?
Her looking confused when she was explaining the medication, and she kind of ignored it and kept doing what she was doing, what she needed to do.
Yeah, that's a big one, right? She just kind of ignored the confused look and kind of kept going. That was good. What else?
A language that she
Language
speak English.
language barrier, right?
Mm.
So we have, an English speaking nurse and a Spanish speaking patient, obviously not understanding each other. Oh, good job. All right. So oh, I won't ask that question yet. What cues suggested that Maria may not have understood the LPN's communication? Kind of covered that, right? Got the confused look on the client's face. So, what should the LPN have done when Maria appeared confused? Because obviously, right, she picked up on the fact that the client appeared confused, right? So, what should Maria have done?
Got an interpreter.
Absolutely. Excuse me. So, just like when the RN went back in with the certified interpreter, right? Maria should have had a certified interpreter, excuse me, um, to communicate. So, part of the beginning of this, let's go back. Oops, I'm going to get there. It says right here that she has a history of hypertension, type 2 diabetes. Maria primarily speaks Spanish and understands only limited English. Her daughter usually helps translate, but is not present during the morning shift. So, why is it important to use that certified interpreter instead of family members when it's possible?
Because the family members can tell switch the story around.
That's a good one. They can switch the story around, right?
Or
What else?
misinterpret the information.
Okay. Family members can misinterpret the information. Good job. What else?
And the interpreter will be neutral.
Interpreter will be neutral. Absolutely. Um, and one thing too, with all of that, they may not convey everything that we need to know, right? They might, depending on culture, depending on patient, right? They may not. Do you ever, I don't know, has anybody ever looked at like a video of like a family speaking another language and interpreting for someone else, and it seems like the person is saying a lot more than the person is translating. Okay. Right. So we may not get the full story and they may leave out things on purpose, whether it's embarrassment, whether it's like, oh, I'm feeling this, but I don't want to, I don't want the doctor to know those kinds of things. Um, but these are issues that we are going to come across in healthcare. We're going to come across patients from different cultures and different countries and speak different languages where you live, okay? Um, can impact that as well. So for example, I have a lot of Spanish speaking clients. All right. So, contrary to my last name, I don't speak Spanish. And so it does present a challenge sometimes. We do have a lot of Spanish speaking staff, but I work night shift and not, limited resources on night shift. So we rely on interpreters. And so the interpreters that we rely on, of course, are, usually over the phone, but there are even for, so one facility that I worked at, we had, he was a deaf mute, got admitted. Um, and nobody on staff, I mean, he used American Sign Language, but nobody on staff knew American Sign Language. And I know enough sign language just to be dangerous. So there's even apps. It was really cool. It was, we had an iPad. We had an iPad app. And so he opened up the app, a American Sign Language interpreter came on, and so he would sign to her, you know, um, whatever it was that he needed, and then she would tell us what he needed, and then we would talk back to her, and then she would sign it back to him. So really important. Lots of different reasons to use professional interpreters. And then kind of like a little anecdote. Anybody ever watched the show House? No. So I love House is awesome. But anyway, there was a scene on there, and I believe they were Asian. Think they were Asian, not 100, can't think it was Asian. This young girl comes in with, I think it was her grandmother. And long story short, the grandmother was not English speaking. And somehow, she, um, she told, I guess she told Dr. House that she needed birth control pills. Her grandmother needed birth control pills for whatever reason. Um, and long story short, the young girl did not know that House also spoke that language. So it turned into a little bit of an anecdote. But obviously the grandmother or the mother, I think it was the grandmother, didn't know that she was in there trying to get birth control pills, thinking, so funny little anecdote. But these are things that could happen. And so again, professional interpreters, using our really good communication is super, super important. There's lots of things that can affect communication. All right. When we look at personal characteristics, right? Age, right? You're not going to talk to a 3-year-old the same way that you're going to talk to a 30-year-old, right? Um, Gender. So gender can affect communication as well. And this could be culturally based, or it could, there's a variety of different parts of that that can affect it. Income, life experiences, our cultural characteristics. So things like the use of personal space, touch, right? What's the word I'm looking for? Some cultures are more touchy-feely than other cultures. Some cultures like to be very close and personal. Others prefer a little bit more personal space. Um, and a lot of this, is things that you're going to learn as you go. Values also can affect that. We already talked about language, which is a huge thing. Um, I will tell you, like when a personal experience, I had to go to the doctor. This was many years ago, I feel like, but my doctor didn't have any appointments that day, so I had to see another provider. Super nice doctor, like nothing against her. She was really nice, but she was one of those people, she talked to me, her face was literally like 2 inches from mine. And I kept trying to like back up on the table. And I'm not, I'm okay usually like in a small, in a tight space for a conversation, but that was just like really, really close. And she was not getting the hint as I was trying to back up from her. Short of just like putting my hands up to like be like, come on, back up a little bit. But it was a little uncomfortable. So be able to recognize those cues. You'll know if you're getting too close to somebody, they may verbalize it or they may like back up a little bit, and that's when you kind of know. Situational influences. So I know everybody's been in a clinical site. And if you've been in, sometimes in a hospital, even in long-term care, you walk in, especially with our older population and those that are a little bit more hearing impaired, right? They got the TV on 100 and you go in and you're trying to have a conversation and you're like, okay, we got to turn the TV down a little bit because, we can't hear you. Physical and emotional state, so if they're in pain, if they're upset, um, things like that can affect how we're communicating. Odors can be very distracting, and this is where we have to pay attention to our nonverbal communication, right? Especially walk into a resident's room or a client's room and they maybe have had a bowel movement or had some gas, right? And that odor hits you as soon as you walk in, right? We have to be able to control how we, what our face is doing. And distractions. If you're talking with the client and people are continuously interrupting, or other people are trying to get your attention, your phone is beeping, other things are beeping. These are all going to detract from us communicating with our clients. And then, of course, why are we having the conversation? So the background, the circumstances, leading to the conversation. So, is it just a normal day? We're doing rounds and we're going in to check and say, hey, hey, Mr. Smith, how's it going? Do you need anything? What can I help you with? Or is there anything I can get you to make you more comfortable, whatever? Or are we walking into a family who has, or a client that has just received not so great news about a diagnosis, and they are upset, and so those are some things that can affect how we're going to communicate. And so that they just got a bad diagnosis. You're not going to walk in all bubbly and happy and be like, hey, so we have to kind of look and take those into consideration when we're communicating with our clients and our families. The verbal or the spoken word is powerful. So once you say something, right, you can't take it back, right? We know words are like daggers, right? Once you say something, you can't take those words back. So we have to be very careful in what we are saying. Nonverbal communication is very powerful as well. And so the nonverbal, that's our body language. And if our verbal and our nonverbal don't match, then it can cancel the meaning of what we are saying. Okay, so we have to be really careful with making sure that our body language matches how we are speaking. Affect, on the other hand, is our mood or emotion. Okay, that's the feeling tone when it comes to our communication, right? So, and everybody has heard those fake customer service voices, right? And so we have to be really careful. We have to make sure that we are using the appropriate effective tone when we're communicating, to make sure, like I said, you had somebody that just found out that they have stage 4 cancer and they're terminal. You're not going to go in all bubbly and happy, right? You want to make sure that your affect meets the circumstance, I guess, would be the appropriate. So nonverbal behaviors, okay? So this is, I always want to say, start with your face, okay? Facial expressions can give you away in a heartbeat, and I know mine. I have to be really careful with mine because my face will do whatever it seems to want to do. Um, so when we're communicating, we want to make sure that our facial expressions are showing the same thing that we are trying to portray via our speech. Distractions. And so you're going into a client's room, and you're going to have clients that are going to be very simple, yes, no type people. They're just going to give you small bits of information that you need. But you're going to have clients too. As soon as you walk in that room and you ask a question, they're going to tell you the story from the day they were born. Okay. And you're just going to have to go and you're like, oh my gosh, I didn't sign up for this. Right. And in your head, you're thinking, I have other patients that I have to see, I have meds to give, I have procedures to do, I have to call this family member, like I have all these other things. And these are all distractions to us, right? Posture is another one. Um, and we'll talk about this in chapter 9 as well when we look at assertiveness. Stand up straight, head tall, okay? Don't look defeated, even if you feel defeated on the inside, right? You also want to make it sure that we are presenting ourselves in an open way. Okay. You don't want to appear closed off to your clients, right? So I'm a big fidgeter. I'm a huge fidgeter. Like, oh my gosh, it's horrible. And you'll see me even sitting here on the chair, my chair will be going back and forth. But what you cannot see is the fact that even as I'm speaking with you and you can't see, my hands go a mile a minute. So I am it's how I grew up. I've always talked with my hands. So I try not, of course, so you guys can't see it. And when I'm working with my patients or working with my clients and their family members, I've had to kind of come up with some ways so that my hands aren't going 100 miles an hour as well as my mouth. So of course, we don't want to do the whole hands in your pocket. We don't want the folded arms across your chest. We want to present that open posture, hands free. Um, and so I'll put my hands like this and I'll just hold them in front of down at my sides, my hands just kind of, hanging in the front of my body. And that helps prevent me from fidgeting. Other things I have tried, I'll hold my pen, or if I'm carrying a clipboard, I'll have that in my hand. That helps to keep my hand busy. But yes, fidgeting is just something that I've always done. Another thing is yawning. Um, and so yawning has, usually when we think of somebody and we're talking to somebody and we start yawning or they start yawning, it shows boredom or, like, oh my gosh, this conversation is just, it's killing me. It's too long. It's too much, right? And so now granted, sometimes you just have to yawn and it's not for any other reason, but we do need to be careful. I've tried to cover up yawning in a number of times, and honestly, it's just because I work night shift. Like I work 10P to 6A. So, sometimes at 3 o'clock in the morning, it's not even like it's just something that happens. Um, but we do want to be careful with that, how we present. So again, open posture, make sure your face matches what you're saying. Confused looks are okay. Like if you really didn't understand something a patient was trying to tell you, you can have concerned looks. But again, you want to make sure that your facial expressions match your affect and your tone of your speech. So these are some active listening techniques. So active listening is super important when we're working with the client. It's the most important part of communication, especially that therapeutic communication between us and our clients. And here we're showing that we're focusing on the client, both their physical as well as their emotional needs. And I mean, I'm not going to say it's easy all the time. Like I said, you're going to have some clients that you're going to go and you're going to talk to and they're very straightforward with what they need, what's going on. And then you have others that are going to, like I said, they're going to start with the story from the day they were born and they're just going to go through that story. So we have to find ways to make sure that we maintain focus on our clients and that we're hearing everything that they are saying. And this requires active listening, right? And I'm sure it happens to y'all now, even in lecture, whether it's me or another instructor, you're listening to us talking in your head, you're going, oh, I need to make my grocery list. I got to get my oil changed. I got to pick up the kids from school. We got soccer practice tonight, right? Everybody does it. Okay. It's, part of reality. But when we are working with our clients, we need to try to focus our full attention on our clients. And so some of the things that we can do are these active listening behaviors. And these active listening behaviors kind of say, hey, I'm listening to you. And these are some things that we can do. These are in your textbook. And I am going to use the examples from the textbook because I don't think they're here. Yeah. Because it's just easier to use those examples. So the first one is restating. So restating is repeating what the client said in just a slightly different way. So if the client were to say, my chest hurts, I can't sleep at night, the nurse could say, you've been unable to sleep at night because of chest pain. Okay. You're just really just restating what the client is saying, maybe in a little bit different way. Or you can just restate it exactly how they said it to you. Clarifying is asking questions in response to a client statement to be sure that you understood. So client says, my chest hurts. So the nurse could say, exactly where does your chest hurt? So it could be like, okay, I said my chest hurts. Now she wants to know where. So I could point to an area on my chest where my chest hurts. Reflecting is putting into words the information you receive from the client at an effective communication level. So, client states, I forgot this example. The client states, I'm sick of seeing healthcare providers and not getting any answers. So the nurse's response in that situation would be you're upset with the lack of answers to your health problems. Okay, so you're just putting the word into words, your words, the information that you're getting from your client. Paraphrasing, just like you would do when you're writing a paper or something along those lines, is expressing in your own words what you think the client means. So if the client says, I don't think I'm being told the truth about my condition, then you can, just paraphrase that. You believe that you've not received the information about your health condition. Minimal encouraging. These are sounds or words or phrases to encourage the client to continue. So the client starts telling a story, and it's not really interrupting, but you're like, uh-huh, go on, yeah, okay. Basically you're just kind of encouraging, like without saying tell me more, you're saying tell me more. Then we have silence. And this is probably one of the hardest ones for a lot of people. Silence or remaining silent is using pauses effectively. Okay. And so a lot of us, when we're having a conversation with somebody other than like maybe family, because around family or friends, a little bit more comfortable. Um, but we generally want to fill that silence, right? Even 5 seconds of silence, right, can feel like a lifetime. And so we really want to be able to use silence as an effective communication technique. And there's a variety of reasons why. It gives person time to gather their thoughts in our older adult population, right? Sometimes, just as a normal, part of the aging process, need a little bit more time to, understand what was asked and then, kind of search for the answers. It could be, that person that just had that devastating diagnosis and they just need you to, sit with them for a few minutes and be present, but really not say anything. So the more comfortable we get with silence, right, the better, better or the less awkward, I guess it will feel. And then we have summarizing and validating, and these kind of go hand in hand. So when you're doing your admission assessment, you're asking all those questions like, why are you here? What's going on? Um, Summarizing is really just taking all the information that you've gathered and presenting it back to your client, right? Talked a lot about chest pain in our example. So you can say, okay, Mrs. Jones, you're here because you have chest pain. It's in the center of your chest. You're rating it as a 5 out of 10 on the pain scale. Is that correct? And this brings us into validating, and the client can say, yes, the information is correct, or they can say, wait, no, it's not a 5 out of 10. It's a 10 out of 10 on the pain scale. Okay. So it gives them a chance to say, yeah, you got the information correct, or it can give them a chance to correct any misinformation that may have been heard in the process. During our interview process, or any interaction with clients, we use a combination of open-ended and closed-ended questions. So give me an example of an open-ended question. Jasmine, are you there? Okay.
Like, can you tell me what happened to your leg?
Okay, very good. Tell me what happened to your leg, right? Um, Open-ended questions, right? We were there to elicit as much information as possible. Give me an example of a closed-ended question.
Did you hurt your leg?
Did you hurt your leg? Okay, that's perfect, right? It can, or make what makes you feel that way. Yep. So yeah, absolutely. So I'm sorry, I did not have the chat open, so I have it open now. I apologize. And then focused questions. Focused questions are even more definitive. Okay, so that could be that pain scale, right? On a scale of 1 to 10, what's your pain level? From, 1 being no pain, 10 being the worst pain, where would you fall in that? So good job. Awesome. Other positive communication. So positive communication, of course, we have to develop that therapeutic communication between us and our clients. And so we develop trust through openness, honesty, integrity, and dependability. We use I messages. So iMessages is something, and I don't know if anybody has ever heard of iMessages before. Well, let's start there. Has anybody heard of iMessages before? Honesty, are you there?
I'm here.
All right, you can't see you. Has anybody heard of iMessages? No. So iMessages are, let's see. If
Yes, I
I were to,
have.
go ahead, Tamisha, I'm sorry.
Yes, I have. You can't put yourself in the documentation. Like, I assist the patient to the bathroom, something like that.
Okay. So that would be an iMessage. Yeah, I assisted the patient to the bathroom. Um, so it's also something that when we look at iMessages, if I were to say to y'all, and I would never say this, but let's say, how do I say this without using an iMessage? Oh my gosh, you guys aren't paying attention to me. You're not answering my questions. You're not listening. How does that make you feel?
Like, you got an attitude.
Okay, like I gotta like I got an attitude. But but it puts you guys on the defensive, like, whoa, wait a minute. What's she talking about?
It
I'm
make
paying
you
attention.
stop and think. Yeah, it make you stop and think, like, whoa, what's wrong with her?
Right, right. And so, but if I were to say something along the lines, I feel that you're not paying attention to me because I can't see you on camera, or there's not enough light in your background. Like that takes more the defensive away, right? Because I'm telling you, this is how it makes me feel without blaming, without judging, right? So we use iMessages. It basically, you're taking ownership of it without trying to put people on the defensive. And it's hard. It takes a lot of practices or a lot of practices. That wasn't even good grammar. But it does take a lot of practice. But basically it's just, or like, oh, here we go, right? Let's say you have that COPD patient that is still smoking 3 packs of cigarettes a day, and you're like, why are you still smoking 3 packs of cigarettes a day? How would that make them feel? Well, that might shut them down and you're not going to get any information out of that. But you could turn that around and say, I'm concerned about your health progressing, and getting worse because you're continuing to smoke, right? So there's a way that we can turn it around so that we don't put them on the defensive. Eye contact is another big thing. Um, we know in American society, eye contact is part of our communication, right? That is something that we use to show respect. Do know that that's expected of us. However, do know that with some cultures, eye contact is not it's they don't maintain eye contact. So that's not them being disrespectful. That's part of their culture, just like eye contact is part of ours. Positive thinking. This is always a good one. Um, and when we look at positive thinking, this isn't going into the room and being like, everything is great and wonderful, and we're all just gonna have a big old, party now. But we also don't want the Debbie Downer nurse, right? Where they don't come in, they don't smile, they don't introduce themselves, right? They're just like, what can I do for you kind of thing, right? Um, but we also know that positive thinking in our clients and people that are sick can have a positive influence, right, on their ability to heal, right? Just know like people get, chronically ill people get depressed, right? And depression can add to not eating, not taking care of themselves, not bathing, right? Not doing the things necessary to get better. So, positive thinking does have a huge part in people's mental health and their ability to heal. Expressing empathy and being very careful, you want to be empathetic, but you don't want to be sympathetic, okay? Empathy is being able to put yourself in their shoes and kind of understand and appreciate what someone is going through, all right? Um, even like, even if somebody is going through a very similar situation to something that you have been through, um, you can never truly know or experience what what someone is going through. And so this is something we, have to understand. We can understand what they're feeling, but we need to keep control of our own emotions. Another thing would be using open communication. Being open and honest is critical in that establishing that a therapeutic communication with our clients and that relationship. And so you want to be honest and open. And another big one is self-esteem. So self-esteem is earned, it is not learned, okay? No one can give you self-esteem and no one can take it away. All right. It is, taking credit for something that you've done, that you've done well, like, let's say you got an A on your exam, right? That you should be proud of that, right? That is, that's something that, should give you a little bit of self-esteem about it. Um, and it just gives you, you're able to recognize that you have something very special to offer. Again, it is earned, it is not learned. No one can teach you to have self-esteem, but you guys, I mean, every single one of you should be proud of yourselves at this point because you're in the last term of nursing school and look how far you've come already. You've made it this far and this is it. You're done, right? You're going to graduate. You're going to get your, you're going to pass your NCLEX and graduate and, go on to bigger and better things. And if you need a cheerleader, I loved being a cheerleader. I was never a cheerleader in school, but I don't mind being a cheerleader. So if you need one, just let me know. I will give you a pep talk. And then, of course, that last part to your positive communication is being aware of your body language and your posture. Again, you want to try to be as open with your body posture as possible so that you're showing them that you are really listening to them and that you're not, looking at your watch or looking at the clock on the wall or fidgeting in my case, trying to make sure that you're just really aware of that. Some of the other negative communication blocks that we need to focus on, these are, these are things that we want to try to avoid. All right. And sometimes these can be very difficult. Why questions? Now, sometimes we have to ask a why question, but we're not toddlers, okay? I don't know if anybody has ever been around a child in that why phase of communication, but sometimes it's enough to want to pull your hair out, right? So imagine being on the receiving end from a healthcare provider. Again, we may have some why questions that we need answers to, okay, but we don't need to be asking a million of them. We also want to avoid those false reassurances, like everything is going to be okay or you'll be fine, don't worry about it. This is not effective because one, you don't know everything is going to be okay. And I learned this lesson and I learned it recently, which is even worse. Um, we had a client that had come in and honestly don't remember why they were. I think she had had a heart attack. Like, I'm not 100% sure because I don't remember exactly why she was there, but I think she had had a heart attack. She also had some mental health issues. So she was schizophrenic. Plus, she had some early dementia going on. So, not 100% there. Okay. Long story short, it's the middle of the night, of course. And I hear her yelling and screaming in her room. So I go in there and I'm like, oh my gosh, what's going on? And she's yelling at somebody in the room that I can't see. Okay. But she's definitely yelling at somebody. And I go in there and I'm trying to diffuse like what's going on. And she sees me, she snaps to reality a little bit. And she starts telling me that somebody has stolen all her money, her credit card, that somebody had burnt her house down, like this whole barrage of things. And I'm, offering some guidance and some like, have you talked to the police? Have you filed a report? Because I didn't realize that the mental health issues were as significant as they were. And and I said, "Oh my gosh, your house burnt down. Like that must have been horrible." What, I was trying to get, it's when I realized that the mental health issues were kind of a little bit more extensive than I thought. And because she just kept going and going and just repeating and repeating. And so at some point in the conversation, I stopped and it's like, it's going to be okay. It was the absolute worst thing I could have said because she was like, you don't know it's going to be okay. And I stopped myself and I took a deep breath and I'm like, I cannot believe I just made like that mistake. I was like, didn't even know what to say at that point because I already knew I had messed up. I had said the absolute wrong thing. And I was like, you know what? You are absolutely correct. I do not know it's going to be okay. And so I had to backtrack a little bit. So be very careful. But yeah, it was just a very whirlwind conversation, and that's just kind of where I fell back. But again, we don't know. We don't know it's going to be okay. So we want to be really careful with the use of that. Probing is another one, and this is where curiosity gets the best of us, right? You're just pushing for information that really we don't need to know. Again, it's just you're curious, like, you want to ask, like, what happened? Tell me more. But we want to be really careful. If we don't need to know, then It's not our job to ask. Judging behaviors. So this is like that COPD patient that's still smoking 3 packs of cigarettes a day. Judging, yeah, probably are silently judging, but it is, it's not our job to condone their behaviors. And, I'm sure that they've heard, quit smoking numerous times in over the course of their illness. But we can still provide quality care to our clients and show respect regardless. Judging their behaviors, we already know that they already know, I'm sure, that it's dangerous for them. We just provide their care. We never want to belittle our patients either. No mimicking, no making fun of our clients. This is not effective. We also don't want to give advice. And this is something, and if it hasn't happened to you yet, it will. Okay. Somebody knows you're in nursing school, whether it's family, whether it's friends, all of a sudden you become the person everybody wants to ask questions. I have a rash on my arm, or hey, I have this pain in the tip of my nose. Okay. All of a sudden, people that you didn't even know, they're going to start asking you questions. Never give advice. One of the biggest things I can tell you is never, ever give advice. Okay. Um, and there have been cases where, you give advice like, oh, it's just a little pain in the nose, probably nothing, put some ice on it, right? And the next thing you know, they have a tumor growing out of their nose. Well, I could have had this fixed, but you told me to just put ice on it, right? Don't put yourselves in those situations. Other things like that patient that has just had that horrible diagnosis. And now they have to choose. Do they want to do chemo and radiation or surgery? What are their options? And they say, well, what would you do if you were in my situation? Stop, back up. For one, no, it's completely your decision. What I can do is help you give you some information, provide you, some guidance, things like that. But I cannot tell you what to do. It is your decision. Okay, Jasmine. Um, that also strips their autonomy, right? If if we're making that decision, then they're not making that decision themselves, and we're taking away their autonomy. So again, it's all about providing education and information, and never just give simple answers. Um, we know how important knowledge is. Knowledge is power, right? The more information that we can give to our clients to meet their needs, the better. Never just blow something off, even if you think it's something minimal. Always give them the most information. They'll thank you for it later. Some of them may look bored to death, like, I can't believe I asked this question. Now she's giving me all this information I didn't want. It's okay. Um, but we don't want to dismiss them, right? With just a simple answer. You want to give it as much information as possible. If you don't have the information at hand, that's okay. Mrs. Jones, I am not 100% sure. Let me go do some research. Let me go get some information, and I'll be back and I will gather that for you and, give it to you. Just make sure that, we are addressing what they need. Um, and then we have SBAR. And so if you've not heard of SBAR or not used SBAR, this is a huge, huge, huge part of effective communication. So SBAR is Situation Background Assessment and Recommendation. And if you've not been using it in clinicals or for communication, this is something that you'll need to understand. So we use SBAR though in different circumstances. We can use it when we're communicating with a provider, or we can use it when we're communicating with other members of the healthcare team, like if, during shift change report. So we'll talk about how to use it with a physician. So if I am calling a provider, okay, hey, Dr. Jones, I'm calling, this is Jennifer, I'm calling from unit, the med surge unit, about Mrs. Smith in room 201, and this is what's going on. So who you are, your unit, your client name and room number, and then what's the problem? Okay. When did it start? How severe it is? So let's say one of my, typical phone calls is usually about a lab. Or I'll just say, all right, this is Jennifer. I'm calling from this facility about Mrs. Jones in room 401. She was found on the floor next to her bed. Plain and simple. Okay. Mrs. Jones was admitted for, um, let's see, I'm trying to think of what would a hip, status post hip or open reduction internal fixation, 3 days ago. She's, alert and oriented times four. She was, getting up to go to the restroom, and her foot got, wrapped in her sheet, and it caused her to fall to the floor. Vital signs are stable, whatever. And then assessment. What do I think is going on? Well, she just had a hip surgery. So, probably, it's not life threatening. Probably need to get an x-ray, right? And make sure that that hip is okay. Um, and then, the recommendation would be, let's get an x-ray. Or if they fell and they hit their head, maybe we need to send them out to the emergency room, whatever. So, situation is why you're calling, who you are, who you're calling about. Background is their admitting diagnosis, their current status information. Assessment is what you think is going on based on those data, based on that data finding, and then your recommendations. What do you want? Do you need a transfer? Do you need a medication order? Do you need the doctor to come see them? What is it that you need? So it's really a very simple process. With shift report, it's a little bit different, right? Because under situation, obviously, I don't have to tell the new nurse that, hi, I'm Jennifer. I'm the nurse for, Mrs. Jones. So it's a little bit different. So situation is one where they admitted what was their chief complaint and what was their diagnosis. So and I'm going to ask you guys a question because a lot of times we don't always get this, but what is the difference between a chief complaint and a diagnosis?
Is the chief complaint what the client is telling you, and diagnosis is what the doctor or the nurses came up with the information?
Very good. Exactly. So let's say you had a client that comes into the emergency room and they had a chief complaint of a headache. Okay. And then we ran some tests and we found that, they have a blood clot or they're having a stroke, right? So we have the difference. This is what their complaint was, and this is what their diagnosis is, right? Came in with chest pain and they determined that I'm having a heart attack, right? So very good. Perfect. So we'll do that during the situation. Then we have background. All right. What's their medical history? Now you don't have to go back to birth now. Okay. Just the things that are pertinent to the patient's care, their allergies, their code status, lab results. How did they, what did they eat and how did they eat? That's always a big one. We need to pay attention to. And mobility. Do they transferred or, do they need a wheelchair, a walker, or are they bed bound? The assessment, vital signs, pain management, diagnostic results, fall risk, medications, and then recommendations is what needs to be done on the next shift. All right. So, do they need to be ambulated? Are there procedures? Are they getting ready to discharge and they need discharge instructions and education? So, it's a little bit more, still very concise. You're hitting all the key points. And then we get into documentation. And everybody's heard if it's not documented, it has not been done, right? So documentation. I did chart audits for a long time. Um, so, and when I first started nursing, everything was paper. It was all on paper. And so trying to read through some charts was pretty interesting. Most of your charting is going to be electronic. Very rarely will you document on paper unless there's, an EMR goes down or, the power goes out, things like that. Always make sure what you are documenting is accurate and factual. All right. You can quote what your patient says in your nurse's notes if that is appropriate to what you are conveying. Be timely with your documentation. Now, we know in certain emergency situations, if you're, in the middle of a code, you're not obviously going to be documenting while you're doing CPR, okay? But for the most part, you want to be as timely as possible with your documentation. And I know this sounds crazy. You want to be thorough, but you also want to be concise, clear to the point. You don't need to write a dissertation on your patients. You just you want to be as thorough, but you want to be, just what you need to say. And this is another one, don't use assumptions. One of the biggest ones, and this is something that I learned way back when I first started nursing, because I would write this and I would see other nurses write this. Patient sleeping. You don't know that patient is sleeping. Patient could be laying in bed praying with their eyes closed. You don't know, and you just assume that they're sleeping. I know it sounds crazy. Um, but mine, I went on to, so I changed from patient asleep to patient lying in bed with eyes closed. Okay. So just what I saw. They're laying in bed, their eyes are closed. I don't, they're, and I would put respirations even in unlabored. Why? Well, if they're laying in the bed with the eyes closed, are they still alive? Okay. I mean, it has happened. Okay. So, but never use assumptions, unless it's something like patient is happy. Okay. Well, how do you know the patient is happy? Okay. Well, you can write patient says, I'm happy, I'm having a good day, right? You want to put something in there to support that, never make assumptions. It sounds a little crazy, but trust me, we have to be very careful. Healthcare is very litigious, as you, I'm sure, know. And you want to make sure, I want to say accurate, factual, and timely. There was, and I don't remember what state it was that I was reading, um, a patient declined, ended up passing away. And in a way, I guess, to cover herself, the nurse had gone back and had added some nursing notes to the client's chart. Um, and in the process of the death investigation, they pulled the cameras and they pulled her cell phone. And so during the time that she documented that she was making rounds on the client and documenting that in the client's chart, she was actually sitting at the nurse's station on Facebook or scrolling, Instagram or Facebook or whatever. So be mindful of that. And I'm always one, don't just be careful, do your job. Your cell phone, Facebook, Instagram, whatever can wait. Make sure that you're taking care of your clients and, meeting their needs. And then the last part of this is conflict resolution. Conflict, it happens. It's just a natural part of life. Here, everybody has different viewpoints, everybody has different needs, everybody has different beliefs. If we all looked and acted the same, the world would be a very, very boring place. Okay. That is one thing that also makes our country great, is that we are all allowed to have different points of view. Now, with that being said, that's usually where conflict arises, right? Um, and so one of the biggest things we need to, when somebody doesn't agree with us, or, maybe not doesn't agree with us, maybe there's just whatever the conflict is, Temper your attitude and your behaviors. Be aware of your initial reaction and take a deep breath. Okay, so we all know I am originally from Brooklyn, New York. Okay. This is something I've had to practice over my many years on this planet. Okay. Just because, New Yorkers, we tend to be a little bit more hot-headed than, some people on this planet. But a lot of times that initial reaction, right? You want to respond immediately and you want to fight back. Um, this is an effective conflict resolution, whether it's working with coworkers or whether it's working with your clients. Because I hate to tell you this, clients, you may have some conflict with your clients as well. Take time to think critically before reacting, whether it's take a deep breath, count to 10, whatever it is. Remember, right? You can't take your words back. What you say, once you say it, those words are out there forever. So be very careful. Take time to think before you react. Like, what are you going to do in response to the information? Treat conflict as an opportunity to voice your own opinions and listen to other side of the story. Okay, again, that's one of the great things about American society is everybody is allowed to have their own opinion. Everybody is allowed to voice it. All right, so we, kind of have to listen to both sides of the story. Choose your approach. This is another one that we have to be careful. All right. A win-lose approach will only escalate the intensity of the feelings involved, right? So if you have to prove that you are right to make yourself feel better, that means somebody else is going to lose in that situation, right? And they're not going to be happy about that. So, we have to kind of figure out. We know that the best choice or the best choice for a solution is going to depend on the situation, but we want to have that win-win, okay? And to have a win-win, all right, in a conflict, it's going to most likely it's going to involve some sort of compromise. You need to use your active listening skills. You may have to do some thinking out of the box as well, so that everybody wins in the situation. And then listen and learn. Conflicts are often based on assumptions and a lack of information, right? How many have ever gotten mad because you thought somebody said something about you? Okay. But it turns out that they really weren't even talking about you. They were talking about something else, but you just assumed that it was about you and you got upset, right? So a lot of times conflicts are based on assumptions and a lack of information. Okay. So, or, maybe you have a CNA that you asked to, go make the bed in room 9 and you get mad because the bed didn't get made and now we have a new admission coming in and you go find that CNA and you start fussing at the CNA because they didn't make the bed. And the CNA is like, well, I was on, and then when you stop to listen, you realize that the CNA was on the way to room 9 to make the bed, but room 8 called and had a massive bowel movement. She was trying to get to the bathroom and it was all over the bed, it was all over the floor. So rather than making the bed, she went to help room 8, right? So can get mad at her, right? And now you're like, oh, I feel bad because I got mad at her. So remember, again, it's how we react initially. And discover what's important. What's the core issue? And again, a lot of that times it's just making sure that you have the information and not making assumptions. And respect. So when I used to do nursing orientations, listen, I'm going to tell you exactly what I used to say to the nursing students. You've got a room full of, sometimes 50 plus nursing students, and sorry, Victor, but most of them are female. Okay, we are starting to get more and more male into the mix, but the majority of nursing students are female. And again, majority of y'all are female too. So what does that mean? We're a little more catty than guys are. Okay. We're harder on each other than guys are on us. And we tend to be a little more difficult to get along with, right? And here we are entering into a profession that is mostly women, right? So doesn't matter. You don't have to like the people that are in your class, in your cohort. You don't have to like anybody that you work with. Okay, but what you do have to do is respect one another and you have to work with each other, right? Because nursing is not a team and nursing is not an individual sport. It's 100% a team sport. You can't do it by yourself. As much as you think you can, trust me, you can't. All right, especially if you're working in somewhere like long-term care where there's 60 residents and just you as a nurse. If you don't have another nurse, if you don't have CNAs that you can effectively work with, there's no way to get it done. Okay. So it's all about respect. Like I said, you don't have to like each other. You don't have to hold each other's hands and sing kumbaya and do all that wonderful stuff, but you do have to respect each other. Um, and conflicts can be emotional. And that's why I said be very careful. Once you say something, you can't take it back. All right. So you want to avoid the name calling, the blaming, because even if you have this conflict, you still have to work with that person again. Okay. So remember that whether it's a client, whether it's a coworker, and always find some common ground to create the highest denominator, whether it's looking out for your clients, looking out for your coworkers, whatever it is, there is usually some common ground. Even among enemies, there's usually one thing that they all can find that they can relate to, right? So just remember all that. Try to avoid conflicts, trust me. Unfortunately, it happens. And we try to do our best to temper the situation so that nobody's feelings get hurt and nobody gets upset. But it still may happen. So, but biggest thing is watching ourselves and how we react. I will tell you that sometimes, like I said, the hardest part is, um, you know, trying to kind of go and prevent the hard feelings from occurring. So. All right. Any questions on chapter 8? Good. All right. So we have chapter 9, which is assertiveness. This is another, it's a little bit, focuses a little bit more on communication styles and stuff as well. But let's take a break. Be back at 3:20.
She called you. She sounds so stupid.
She said, start to John her. And it's funny because I talked to someone this night, we had a conversation. It started with me in the bedroom, she might let her down.
Exactly.
Now,
Yep.
I
Oh, yeah, she do down here.
Vanessa,
All right. So we will go into chapter 9. So chapter 9 is about assertiveness. Let me share. So there are three major behavioral styles when it comes to communication, or actually behaviors, but it's aggressive, assertive, and non-assertive or passive. All right. And so the verbal, the nonverbal, the effective communication, those are all going to play into these behavior styles, right? So we will start with non-assertive. So non-assertive is fear-based behavior. It is emotionally dishonest. It is self-defeating type of behavior. Okay. So we look at non-assertive nurses. These are nurses that tend to look the other way. They avoid conflict. They take the easy way out. They don't really participate in that healthcare team. They don't express feelings, needs, ideas. Um, it basically says that I don't count. Okay, that's basically that non-assertive passive behavior just says I don't count. I don't matter. You matter. And so it's a little bit different. They kind of pass the buck. They'll, like they'll, it's somebody else's job, they may limit contact with a client that they're uncomfortable with. Again, if they, if a patient or a client's asking questions, they may be like, oh, you need to ask your doctor or your healthcare provider, or, ask somebody else. Basically, again, like I said, it's basically they're going to take the easy way out. Um, your aggressive behaviors, they violate the rights of others. They're more outspoken. It's usually an attack on a person rather than the behavior. It's more anger based. This is like your body language, your eye is glaring, leaning forward. It's very, it's destructive, it's self-defeating. And I'm sure everybody has come across an aggressive person in their life that has had this type of behavior. Um, they too, as an aggressive nurse, they're not advocates for their patients or their clients because they're too busy taking care of themselves. Um, this is like when I was talking about communication, right? We look at conflict resolution, you step back, right? Temper what you want to say. Think about what you are going to say before you react. And then we have assertiveness. I have somebody that's trying to come into the class that's not in the class, but we'll just see what happens. Assertiveness is another name for honesty. All right. It's a way to live the truth from your innermost being and express this truth in thought, worth, and deed. So it's taking a positive stand. It is being confident in your statements. It's speaking openly, but not violating anybody's rights. It's standing straight and tall. It's facing the person. It is making eye contact. Assertiveness is a tool, it is not a weapon. All right. So it is, I don't know how to explain it. It's sticking up for yourself, it's being direct, but it's not violating another person's rights. Um, and it's like I said, even with communication, it's not what you say, but how you say it, right? And so we have to be careful again between, being assertive and being aggressive. I'm trying to figure out how I want to say what I want to say. And for some reason, it's just not coming out the way I want to say it. So being assertive, let's say it's taking your break when it's time for you to take your break. It's sticking up for yourself. It's if a doctor writes an order and it doesn't seem right, okay, maybe the medication dosage is too high or whatever it is, It's not confrontational, but it's calling the doctor and say, hey, I don't think that this order is correct. Can we discuss it? It's a client that's giving you a hard time. All right. And letting him know, like, hey, I understand you're frustrated, but let's sit down and figure out what we can do to make this better. Right. Um, Trying to think of what else. It's even taking criticism, right? How we accept criticism. And I know nobody likes to accept criticism because, tends to hurt our feelings. But even, it's something, saying like, okay, clarify this. I want to make sure that I understand so that it doesn't happen again, right? Rather than going into that defensive tone and taking it the wrong way. So like I said, it's being honest, it's being true, but it isn't being aggressive. You're advocating, you're standing up for yourself. However, you're not infringing on anybody else's rights. Other things with assertiveness, own your feelings. Okay. Everybody has feelings, thoughts, ideas, all of those good things. Okay. Own them, own your feelings. Don't blame others for the way that you feel. And make your feelings known by being direct. That's where those I statements come into play. And always make sure that your nonverbal communication matches your verbal message. And this is important as we start to go through some of these other things. Negative interactions, using your coping mechanisms. So, nursing is hard, not going to lie. You're going to come across a whole lot in your nursing career. Different people, different things are going to happen. And you have to be aware of yourself at all times. And a lot of self-reflection is required for nursing. But some of the negative things that people tend to do, coping mechanisms, and some are more effective than others. Some are positive and some are not so positive. Projection is a coping mechanism where people attribute their own weaknesses to others. Okay, so, you know, um, it's a waste of energy. Okay. It's you're trying to make yourself out better than than you could be, I guess. Like, wow, I think one of the
Is it
famous ones that,
like, I'm sorry,
huh?
is it like putting your feelings on someone else?
Yeah. Yeah. Or like one of the worst ones I hate, and I've heard this ever since, because I started as LPN too, guys. Um, you're just an LPN. I'm an RN. I'm a real nurse. Okay. I will tell you as a real nurse, as an RN, okay, I know LPNs that can run circles around that's some of the RNs that I've worked with, okay? Um, but it's just these are, just own your feelings, own your issues. Don't try to project them onto another person. Rationalization is actually a logical but untrue reason is offered as an excuse for the behavior. Okay, so labeling a client as a troublemaker or uncooperative. It's not assertive, right? It's an indirect type of behavior on the part of the nurse. And so now this patient has this label of being uncooperative or being a troublemaker, right? And this is going to get passed from one nurse to the next. So we've now labeled this person as this, and it's going to affect the way other nurses interact with this client, right? Which could be an issue when it comes to their care. And then we have denial. And denial, unfortunately, the nurse can use this to excuse personal or responsibility, not reliable. So, this is always something like, I didn't know, it's not my job. It's definitely something that we want to avoid because unfortunately, nurses have a lot of autonomy. We have to really know what it is that we are supposed to be doing. Um, and so, we want to just kind of avoid that negative projection um, and try to be as positive with our communication and our interactions with members of the team as well as our clients. Which brings us into the problem solving steps, okay? So, problem solving is a series of steps, much similar or very similar to the nursing process. And so, of course, the nursing process is a little bit more focused, but we have problem solving steps. And when we look at problem solving, there's all sorts of different problems that we are going to come across. Some of them, we may not have to go through the full problem solving steps. We may be able to skip to, the alternatives and evaluation. Others, we may have to start back at the beginning. So the first part of the problem solving is define the problem, okay? Sometimes what we see or perceive as the problem really isn't the problem, okay? So this is why, we have to sit down and we have to really look and define what the problem is. And then we have to decide on a goal. What do we want to happen? All right. So once we have, let's say, I'm trying to think of a problem. Let's say let's say we're not getting along with one of our coworkers, okay? Whatever the reason is. We're not getting along with the coworker, or maybe we heard, like I was talking about earlier, maybe we heard that the coworker was talking bad about us, okay? We're trying to define the problem. So, what's the problem? We have a coworker that we're not getting along with, all right? Then decide on the goal, all right? Review our problem, how do we improve the situation with our coworker? And so what can we do differently? All right, how do maybe we temper our language, our approach, whatever it is, we want to decide on a goal, but the goal is, right, we want to get along better with our coworker. So we're going to, when are we going to do this? Just like with the nursing care plan, we can do short term, how we can try some things out. So maybe we're looking like within a couple of days, or it could be long term. Maybe it's going to take a little bit longer to fix this relationship between you and your coworker, whatever it is. When we decide on a goal, again, just like with the nursing care plan, it needs to be realistic, it needs to be measurable, and it needs to be time referenced. And then we choose our alternatives or our interventions, okay? So these are the approaches that we are going to use to try to attain that goal, right? So we're going to look at ways, how can we improve the relationship between me and my coworker? And so this could be anything that you think would help. In some situations, even choosing a goal like do nothing and see how it plays out, or an intervention, do nothing and see how it plays out. You can use that as one of your interventions as well. But better, um, you know, um, using a different communication style. I'm not saying bring her flowers and candy and all that stuff, right? But trying to find ways to improve your communication. And then you want to try out the alternatives. All right. So I've improved my communication. I'm more assertive, whatever it is, and evaluate. Did the relationship between me and my coworker improve? Did it get worse? What happened? And if, then like, just like with that nursing process, if we aren't getting anywhere, then we go back to the drawing board, right? And we try to find additional interventions to try to assist us. But you can use the problem solving process for anything, Whether it's you want to practice being more assertive, all right? How are some, what are some ways that you can practice to become more assertive, right? Um, or, how do you get better with your critical thinking skills, your clinical reasoning skills, right? So all of these things you can use the problem solving process. So again, you're going to define the problem, you're going to decide on a goal, choose your alternatives, try out your alternatives, evaluate the effectiveness of your approach, and then repeat the process if the solution is not effective. And this is where assertiveness is really going to come into play. And so we're going to talk about some workplace or work related issues. So, for one, assault. Okay. Workplace violence has existed in healthcare facilities forever. Okay. Why is it more prevalent? It's really not more prevalent. What it is now, the power of social media and technology at our hands, right? We just hear about it a lot faster and more often, unfortunately. Nurses are frequently targets of violence, hostility, sexual harassment, and discrimination. All right. So it accounts for 10 to 11% of all workplace injuries. 54% of nurses experience verbal abuse by clients. 29% experience physical abuse by clients. It's a huge number. Okay. In OSHA, which is the Occupational Safety and Health Administration, they have published guidelines to prevent workplace violence. And it does stipulate that management has to have a commitment to keep its workers safe. And I know sometimes when we think of OSHA, we think of like mechanical and chemicals, right? Things like that. But because workplace violence is a huge issue, and OSHA's job is to keep people safe. And so it does have the workplace violence guidelines. And a lot of this, not all agencies have complied with OSHA guidelines. But, more and more so as we see the increase in workplace violence, more and more people are becoming involved in trying to keep healthcare safer for people. Manipulation. This is another one. And I will tell you, your mental health patients are probably the most, what's the word I'm looking for? The best at manipulation. So feelings and needs of others are disregarded, or other people are treated as objects to fulfill the needs of the manipulator. And I'm sure everybody has come in contact with a manipulator at some point in their life, whether it's a family member, whether it's a friend, whether it was a previous coworker, current coworker. Manipulation is something, unfortunately, that we've all had. And like I said, mental health patients are like, they got this down. Dealing with a manipulator is very difficult. Okay. And so you have to be assertive. You have to be assertive. That's the best approach with these patients. And most of the time, when working with a manipulator, they are going to resist as much as possible. They are going to resent you, and they're going to try to get around you and try to just go and manipulate somebody else. You may even at some point have to stop being involved if the problem cannot be worked out. But the biggest thing working with a manipulator is setting limits. And that's where the resistance and the resentment is going to come into play. You need to set the limit with these clients. And again, so like I said, you may have to refuse to participate in that person's care if it continues. Insidious aggression. So what does the word insidious mean to you? Has anybody heard that before? So insidious aggression is aggressive behavior in the workplace. All right. So these are things like incivility, interpersonal issues, hostile acts that are not obvious, okay, to others. Meaning, there's being, things that are being done that are kind of like, behind the back kind of things. Like it could be, um, a staff member that just refuses to interact or altering things on the background to make it look like you didn't do your job appropriately. The problem with any type of aggression is that it results in job stress, less job satisfaction, less job commitment, less satisfying relationships, higher levels of anger and anxiety, and lower levels of overall well-being. And if you are the target of insidious aggression, you're more likely to quit your job because nobody wants to stay somewhere, right, where they feel uncomfortable, that they feel threatened, right? That's always a big one. And part of the issue is, okay, especially if you know who the person is, if you're not sticking up for yourself and you're not being assertive, then you're just giving them the opportunity to continue the behavior and they're going to continue. All right. So you, again, as a nurse, you have to be assertive. You have to stick up for yourself. Um, you have to advocate for a safe workplace. And that includes some of these people that are behind the scenes trying to cause problems. And I'm sure people have come across these types of people in their lifetime. Sexual harassment. Who'd have thought sexual harassment? Can happen in any type of environment. But sexual harassment is it about abuse of power? Okay. It's not about sex, it's not about passion or love or anything. It is strictly abuse of power. And so, and it's unwanted. And so most incidents, unfortunately, of sexual harassment are not reported. So this is any unwanted sexual advances or other physical or verbal conduct of a sexual nature. So, could also be creating that hostile environment, right? Where, the person that is, harassing someone, intimidates or interferes with your ability to perform your job. If you are the target of sexual harassment, the first thing that you need to do is confront the person that is harassing you. All right. So you have to assertively, okay, tell the person clearly what they are doing is offensive to you and it is unwanted. And this is where your body language and your verbal communication need to match, okay? And so be very careful. Employers do have the responsibility to correct any unwanted behavior. So the first thing that you do is confront that person. And then if the unwanted behavior doesn't cease, you report it to your supervisors, department heads, whoever it is that you need to report it until you are heard. Then, I always say document everything. Document everything. If you are ever in a position where you're being harassed, you need to document everything. And like I said, you're going to confront them first. And if it doesn't stop, then you report it to whoever you need to until it does stop. Lateral violence. This is another one, and I'm sure everybody has heard the term nurses eat their young. This is something that, even back when I was in school, I actually had to write a paper on lateral violence. But lateral violence occurs between nursing colleagues, okay? And so it could be physical, it could be verbal, it could even be emotional abuse. But like some of your, like you're talking to someone and they're like rolling their eyes, like, oh, she doesn't know what she's talking about. Or, anything to try to belittle somebody. It verbal, it is backstabbing, it's withholding information, right? Like, especially like critical information regarding clients, like, oh yeah, didn't tell you that your patient's potassium was a 7, right? It's sabotage, it's backstabbing, it's scapegoating, it's failure to respect privacy, it's broken confidences. Like, you tell, somebody something and in confidence, and they go around and they tell everybody else. And I'm going to tell you, I was listening to what was I listening to? I think it was just a vlog. 4 nurses. I want to say they were in California, not 100% sure. But there was 4 nurses. 2 of them were newer nurses. 2 of them were older nurses, or like not old, but like been nurses longer. Um, and they were I want to say the 2 younger nurses, the newer nurses, they were like sharing pictures of a patient, of a client that weren't in the best light, and making disparaging comments about the clients in these text messages, thinking that, hey, they're all friends, it's going to stay between them. Well, the 2 nurses that had been nurses longer were like, oh, we don't want any part of this, and reported the other 2 nurses. And the other 2 nurses ended up losing their nursing license. So not that that is an example of lateral violence, however, it does show you one thing that I will always say is your coworkers are not your friends. Okay. Everybody tends to look out for number one, which is usually themselves. So be very careful with what you share, who you share it with, whether you are at work or not. Because even those that you think are your friends turn out to not be. Vertical violence is a little bit different. This occurs between people of unequal power. And so they could be a nurse and a student. It could be a nurse manager. Um, it could be a new nurse and a seasoned nurse. It can be an instructor and a student. But the purpose of this, or basically the behavior humiliates and undermines confidence. The person who is bullied ends up feeling fearful and unsafe. Again, the term here is incivility, which is the common terminology used to describe hostility among nurses. And again, we can have the lateral violence, or we can have the vertical violence. And unfortunately, this is something that happens. I was doing, so I'm in school for my DMP, okay? And during one of my classes, we get to learn about what other DMP students are doing for their projects. And one of the nurses is actually doing her project on incivility in the workplace. And when I started, because we have to do discussion questions and stuff too. And so when I was reading her discussion and I went to do my own reply, I was very discouraged about the amount of the level, or the percentage of incivility in the workplace. I don't understand it. Like, I don't understand it at all. Um, and I get it. There's people that are bullies. I understand that. But I guess what I don't understand is you have to have some level of empathy and caring in order to be a nurse. And I understand that not everybody is wanting to be a nurse because they just want to care for people. Some people are in it just to have the paycheck. And I will tell you that if you're in it for the paycheck, it's not worth it, because I can tell you jobs that you're going to make a lot more money and do a lot less work. But so I don't understand it. I don't understand it. I am not perfect. I have, previous coworkers that I've not gotten along with. That's just, that's life. However, bullying somebody and treating someone poorly just doesn't, I don't understand it. I don't understand it. That just goes against everything that people want to be a nurse for. And I just won't ever understand it. It doesn't make sense to me. Um, More about workplace violence. Um, so workplace violence doesn't just come from, employees. It can come from outside influences as well. And there's a variety of things. But things that lead to workplace violence, personal factors, body language, you know, um, their communication, the nurses' attitudes and behaviors also play into this. Um, how we approach people, is also super important. Even that client, that person that is really just annoying or giving you a hard time or maybe getting loud, how we approach them, is important. Workplace practices. This is where, like I said, OSHA has those guidelines for workplace safety, but workplace practices aimed at improving safety for healthcare workers are critical. Um, Even looking at security personnel, that's key. How do we have our security personnel in place? So, are they in uniform, armed and dangerous, looking big and bad, or are they in, polo shirts and khakis, right, looking a little bit less assertive, or in a shirt and tie, right? How they present as well. Um, Environmental factors, one of the big ones is the type of client seen and the location of the facility. Um, if the hospital is in a high crime area, then that kind of shows us, right, the type of client that we are going to see more often at that facility. Another risk factor for hospitals and psychiatric facilities, guns carried by clients, families, or even friends of the clients, mentally ill. These are all environmental factors. So, like, I'm going to tell you, there's before I moved here, this was about, oh, I wish I can remember how many years ago, but one of the hospitals in the area that I lived in Virginia. So they had a psych patient who had gone into the emergency room. Now, this emergency room, like they had just done, I don't know how much, like they did a whole lot of remodeling to try to make it more aesthetic, I guess would be the word. Um, and so like if you go like most of the ERs that I know like that I've seen, right, you have the reception area, and in behind the reception area is the emergency room, right? You go right through the doors. Well, they decided to make it more aesthetic and more friendly, I guess. The reception area was literally in the middle of the waiting room. Okay. So a psych patient had been, I think they've had been escorted out by security or something had happened. Anyway, I don't remember because it was a long time ago. Anyway, the patient came back with a knife and was able to gain access to that admission area and stab one of the ED techs. Now, ED tech lived, he was okay. But this person who had stabbed the ED tech had known that the security guard was going on break or had left to go on break or wasn't at that nurses or wasn't at the admission station, so he was able to gain access. So these are things though that we have to be aware of. Another interesting story, same hospital by the way, just a couple of years later, they have, I forget what it's called, it's a specialty, it's the heck is it called? I almost worked there when I was at LPN. Anyway, it's part of the main hospital, but it's in a separate building. Client was in there. He had a terminal diagnosis, older gentleman. The wife comes up to the unit, goes into the room, kills her husband, and then kills herself. So it was a murder suicide. And Nothing the staff could, nothing the staff can do. But these are things that unfortunately, okay, within healthcare, and I know that you guys have all heard the stories about nurses being attacked and shot and all sorts of things. And my whole goal with this is safety first, being really aware of your surroundings. The other one is risk diagnosis. So majority of assaults occur from a minority of patients. Okay. So if they already have a history of previous violence, that's a strong indicator, but we don't always know, right? This could be the first time we're coming into contact. We don't know if they have a history of violence. And so we need to be able to learn how to read cues for potential risks of violence in our clients, and who we are dealing with. Now, obviously, if they have mental health disorders like your affective disorders, your paranoid disorders, or your chemical abuse and dependency, dementia patients too. I work with a lot of dementia and Alzheimer's patients, and their behavior sometimes can be very risky. Um, and then, of course, clients or families undergoing extreme stress. So, one of the biggest things that I always want people to understand is situational awareness. All right. Situational awareness is knowing exactly what's going on around you. All right. These are probably one of our biggest downfalls. Okay. How many of you go, like, even just walking around the mall or walking outside? People are buried in their stinking phones. They have no idea what's going on around them. That opens you up for so much. It opens you up to get pickpocketed, your purse gets stolen, your phone gets stolen, attacked because you don't see anything coming because they're so focused on those phones. Um, so know what's around you. There was a shooting in Seattle like last week, this week, earlier over the weekend. One of my former students was in that shooting. He didn't get hurt, but it happened right where they happened to be at. So pay attention to what's going on. When you're at work, know where your exits are, know who's coming in and on your unit, know who's on your unit. Like I know like I have usually on average, I have about 30 skilled residents. Okay. One of the first things that I do when I get there, I get report first and I'll do my narcotic count and all that stuff. But then the second thing I do is I do a round. I go in and out of every room, whether it's full or empty. I want to know who is in that room and what's going on. Is there family in the room or is it just the client? Because a lot of times with, even though I don't do long-term care, we do tend to be a little bit more lenient, right, with visiting hours. So families have 24-hour access to their loved ones. So I want to know who's on my unit and what's going on. All right, if there's family in there or not. But know exactly what's going on. Know where your exits are. Always have an escape route in place. Always have an escape route in place. So again, this is where it's really important for you to know where you are and what's going on. If you are getting into a confrontation and you are in a residence or a patient's room, a client's room, okay, never turn your back on the door. Always have your back to the door. You want to stay to the side of the door. You do not want to block the doorway. Couple of different reasons. If you block the doorway, then that could be a threat because it may seem like you are preventing that person from leaving that room. So stand to the side, but always have your back to the door. Maintain that open body posture. Keep your hands out of your pockets. Always big things. I know that's hard to do. Keep your hands out of your pockets, uncross your arms, uncross your legs. Make sure your hands are visible so you are not a threat to anybody. Call them by their name. Straight up call them by their name. Remain calm. This is always a big one. Remain as calm as possible. All right. You don't want to yell, or if they're yelling at you, this is one of the best things that I learned just over time when I was raising my kids, because we know kids can yell. Talk calm. They're having a fit, right? My kids would have a fit. They'd be throwing their little temper tantrum. I would whisper. And why? Because then they'd have to stop to hear what I'm saying. All right. So speak softly, quiet, controlled voice, remain calm. Don't, stand still, don't fidget. That's always my big thing. I'm going to have to stop. Keep a distance between you and the person. All right. You want to stay, especially stay out of hand reach. I always say stay out of, arm reach, not hand reach. Don't point, don't order them, don't challenge them, don't threaten, don't try to intimidate them. Make eye contact. Never turn your back. Never turn your back. And sometimes you may just have to be very firm with them. They may back down, but again, your protection is your protection. If you get hurt, if something happens to you, who's going to take care of those patients? Okay, so you want to protect yourself. Um, some of the things that we may start to see in those behaviors, okay? Unusual behavior changes. So maybe they were okay. Now they've got some changes that we're like, what's going on? They start to not be cooperative, start to curse or other hostile communication. They anger easily. We may see these in some of our coworkers too. All right. So remember, I always say this, workplace violence doesn't always come from our clients. It can come from our coworkers as well. So if they're starting to spread more gossip and rumors, if they, start to saying that they're having some sleep disturbances, increased irritability and anxiety, they start making some uninvited sexual remarks, they have hostile responses, um, they, then eventually, they may start with, things like poor me, play the victim. They may start to leave notes with threats, violence, or even sexual contact. They may start to verbalize plans or desire to harm someone. They may start stealing property. They are less interested in work and assignments. Increased arguments, increased physical accidents and injuries. And then as this anger starts to intensify even more, okay, violence can erupt either against them, oneself or towards others. One of the biggest things that I can always this and hindsight is 2020, right? We know this, right? You can go back to some of the school shootings and other things that have happened where behaviors and other things have been ignored because, people were afraid to speak up. So, for one, make a personal commitment to follow prevention guidelines, okay? The focus is on gentle defense, not offense. Of course, you want to protect yourself. All right. And so there are things. There may be trainings that are offered by your organization. There may be trainings that are offered through like the police department. So you may have to like do some research if you're not, if you're not sure. Um, you want to be as prepared and hope it, be prepared and hope it never happens, right? That's the key. Be familiar with your workplace policies, be alert to warning signs, and take all threats seriously. This is what he was saying. Like you look back at Columbine and some of these other things that have happened over time, okay? And there's always warning signs. All right. After the fact, people will say, "Oh, well, yeah, they did this, they did that, they had this obsession with guns or this." Okay, and people were afraid to report this behavior. This is the problem because we cut it down to, oh, they're just being teenagers or they're just this or they're just that. Take all threats seriously. Take all threats seriously. Report them to management. Encourage others to do the same. It is much easier I would rather report it and have it unfounded than not report it and have something happen, right? It's not, as long as you're doing it in good faith, that you're not just you're not looking at the workplace violence and the incivility, right? Take all threats seriously. Now, I'm from I'm an older generation, okay? I'm a Gen Xer. All right. So we would say stuff like, oh, I could kill him for that, like things like that, right? Those were things that we would say. Now you can't say things like that, right? Because of the way society has become. And we know this, and I don't say that anymore, but we do have to be aware of, like I said, being aware of your surroundings, reporting the things that you need to report is super important. There's so much that has happened. And it's scary. And I don't want anybody to be scared. I don't want anybody to be nervous. I really just want people to understand. And situational awareness is the start of that. All right. Any questions on chapter 9? All right, so we're going to do chapter 14 is next. Let's take a break. Be back at 4:20. All right. So now we have chapter 14, which is the interdisciplinary care team. I will share my screen for you guys. All right. So the interdisciplinary healthcare team, and I'm sure you've heard this term numerous times um, throughout throughout your nursing adventure here. So it's a group of professionals who contribute to care and treatment of a client. Okay. They display mutual empathy and understanding. They work together to meet common objectives and they promote positive patient outcomes, which the most is, right, to restore health. So the members of the healthcare or the interdisciplinary care team, we have our nurses, right? These are our nurses, our RNs, our LPNs, our UAPs. UAPs have a variety of different names. Okay, I'm gonna probably get some of them, not all of them, but like your CNAs, your care techs, your patient care partners. I'm trying to think of what else they call. It could be your ED techs. So a variety of different types of UAPs. Could be nurse practitioners. It could be physicians, whether it's a surgeon or residents, interns. It could be the nursing case manager, the dietitian, your lab personnel. And then, of course, we have our therapists, our PTOT, speech, respiratory, and social worker. So tell me, what's the difference? Because a lot of people don't, some people know, some people don't. What is the difference between occupational and physical therapy?
Physical having to do with the body, occupational have to do with everyday living.
Very good. Perfect. Yeah. Physical therapy, a lot of times it's to build strength, right? And then occupational is working with your ADLs, right? And then we have social workers. Okay. Other things, like in long-term care, the activities director may be part of the interdisciplinary care team as well, right? Because we know doesn't matter how old we are, socialization is very important. We don't want people just laying in bed watching TV all day. So activities may be part of this. The intra-disciplinary care team, these are health workers of the same discipline that worked together to integrate care that provide clients with all the services they need to maintain safe, quality, comprehensive healthcare. So this is like the levels of nursing. Your UAPs, your LPNs, your RNs, that would be an intra-disciplinary care team. So this is, and I don't think this chart, I think we just made this chart. This isn't in your book, but this is a little bit about the different levels of nursing. Okay, so I'm going to start with the RN. So we have our registered nurses, all right, and so registered nurses are the largest group of healthcare workers in the US. All right. And there's different levels. There's an associate degree program. So associate degree programs, usually around 2 years, takes about 3 years to complete, especially like if you're in like a community college setting. And we have programs like Fortis, right, that offer RNs in an 18-month program. I'm trying to remember how long mine was. I think my RN was 18 months. They have bachelor's degree programs, which are generally your 4-year programs that are in like your public and private colleges and universities. RNs are a little bit more independent in nursing. And so they plan care, they coordinate all activities of care. They do have a little bit higher more specialized knowledge and judgment. They provide education and teaching to clients, act as a client advocate. They must practice in accordance with their Nurse Practice Act. With RNs, there are certifications that are available. So obviously the first thing you have to do is pass your NCLEX. And then I'm not even going to get into it, but there's a lot of different certifications out there as an RN. The advanced practical or the advanced practice registered nurse. And so these are those that have had advanced degrees, usually a minimum of a master's degree. And so this is like your certified nurse anesthetist, your nurse practitioners, your certified nurse midwives, your clinical nurse specialist, your nurse executive, your certified nurse educator. They again must practice in, within their scope of practice. Um, Minimum of a master's degree. There are some, I don't know, I haven't looked into it. At one point there was a push for nurse practitioners to get their doctorate to have their DNP, but I'm not sure if that's accurate anymore. But there's two different types of doctorates. There is your PhD, which is a research doctorate, and then you have the DNP, which is a practice doctorate. So I'm working on my DNP, which is a practice doctorate. Then we have our LPNs, our wonderful LPNs. So LPNs have 12 to 18 months education. And so if it depends. Like the 18-month programs, that's the one that I went through. I went through an 18-month program. I went through a vocational high school that did adult education. And so I went to a high school basically in the evenings to do my LPN, which was an 18-month program. A lot of them have cut down. It just depends. 15 months really is the average for LPN program. And you guys get the fundamentals of clinical bedside care. You also get your sciences, right? Your anatomy and physiology, as well as your med surg and peds and OB and all that stuff, mental health. You still must practice in accordance with your Nurse Practice Act. You must still take your NCLEX. But you generally, as an LPN, will work under the supervision of a registered nurse. Now, this will depend on where you work because I will tell you, as an LPN, I didn't have an RN supervisor when I worked in pediatrics. I worked directly for a provider. So my supervisor was an MD. So it depends. Generally, you will work under a registered nurse. But it will depend on where you work. You can work under the supervision of an MD or a nurse practitioner as well. So the roles of the registered nurse, they can they can practice in all aspects of that nursing process. So plan care, coordinate all activities of care, provide care that requires more specialized knowledge and judgment, teach clients, families, and other members of the healthcare team, and act as a client advocate. As an LPN, so you will care for clients within the scope of your Nurse Practice Act. While upholding clinical standards, you will provide care in basic and client situations under the general supervision of an RN, physician, podiatrist, dentist, as determined by your state Nurse Practice Act, regardless of the site of employment. So I noticed down here that some of the dentist office actually employ RNs, the ones that do like the dental surgeries and stuff like that. So for the use of anesthesia, they'll have RNs to help monitor the patients while they're under anesthesia. And I don't know if this is a full-time or a part-time position, but where were we? We were at the mall. They have like a lot of like outdoor malls down here. But anyway, some of the places that do piercings also hire RNs to do the piercings. So I thought that was interesting, but I don't know, just interesting little things. But your primary responsibility is in the care of vulnerable populations with chronic stable conditions. So you guys provide client care. You'll serve as a client advocate. You'll provide education as well. You need to be able to communicate effectively and then function as a collaborative member of the healthcare team. So these are in your chart. Okay, so this is just broken down a little, or in your textbook. My apologies, can't not in your chart, but in your textbook. And so we look at the differences between the roles of RNs and LPNs. And so look at care manager or manager of care. The RN can control decisions regarding staff and care of clients. Okay, so how many RNs need to be on duty, how many CNAs, how many LPNs, those kind of staffing decisions, as well as, things that we need to worry about regarding client care. LPN, you are in a long-term care facility or even in other community settings, you guys are first line managers. All right. So most LPNs will be charge nurses in a long-term care facility. The facility I work at for the long-term care side, the assistant director of nursing is an LPN. So there are management opportunities for you guys as well. Again, you'll work under the supervision of the RN or the physician. Care providing, the nurse or the registered nurse can initiate all phases of the nursing process and make those nursing diagnoses, whereas the LPN assists with the phases of the nursing process. Those, like I said, the RN can work all 5 phases. The LPN will assist the RN in developing that plan of care. But LPNs are going to be spending a lot more time at the bedside with these clients, so they will identify new nursing problems and report those back to the RN. Teaching, the RN will initiate all health teaching for clients, okay? So as an LPN can't do new teaching, however, you can reinforce and assist the RN with health teaching as directed. Right. So initial education, initial discharge instructions, all of that stuff is done by the RN, and then the LPN does the reinforcing and the follow-up. But like I said, okay, LPNs have charged positions in long-term care. Okay, so you are responsible for the patients that are under your, if it's a unit or a set group of patients, whatever it is, you will be in that charge position. So you will direct the plan of care for them in any available, if there's something that's outside the scope of practice, according to your Nurse Practice Act, or something that the LPN is unsure of, there is an RN that they can collaborate with or consult with. But they assist with the decision making. They also assist with care coordination, and you are responsible as an LPN to assign and supervise the UAPs. So you will have nursing assistants or care partners, whatever care techs, whatever they're called in your respective state. You will be responsible to supervise the duties that they perform. Acute care settings are a little bit different. All right. So long-term care settings, again, you have a group of clients, whether it's a whole unit, a half a unit, whatever it is. When we look at acute care settings, we provide care, and obviously we still provide patient care, but the delivery may be a little bit different. Okay. So we have the total patient care method. Total patient care means one nurse plans and delivers the care. All right. So this is a lot in our ICU patients where there is a nurse to maybe 1 or 2 patients, and you are performing all of the care for that patient. And so you don't have a care partner, you don't have a CNA, so you are responsible for all that care. Functional nursing, and so this you are assigned to complete certain tasks rather than for specific patients. So for example, let's say we have a 10 patient unit, one nurse will do, let's say, one nurse will do all of the medications, one nurse will do all of the treatments, right? So that's basically a functional method. With team nursing, this is something that a lot of the hospitals were going to, when I was leaving Virginia, I was talking to some of the hiring managers. They were kind of going back to this team nursing where you have a team, which is basically an RN, an LPN, and like a CNA. Um, and the team method is based on the belief that goals can be achieved through group action. All right. So again, you have this little group, and so you'll collaborate together to care for the patient. So I don't know, it really just depends, but of course, each member of the team is going to work within their scope of practice. We know LPNs are more task oriented, so maybe they're the ones doing, the medications and the treatments. RN is do, I don't know, whatever. And then, the CNA is responsible for patient care. So this is something, as we were pulling LPNs back into the hospitals, this is kind of where they were going with that aspect was in the team nursing, especially units like med surg, primary nursing. And so the intention for primary nursing was to increase quality of care for patients. But this primary nurse assumes 24-hour responsibility for planning the care of one or more patients from admission to discharge. And then we have our case management and care management. So this is another thing that I noticed is starting to open up to our LPNs as well. Case management focuses on achieving client outcomes within specific timeframes using what we call clinical pathways. Clinical pathways are critical paths. They're tools that identify incidents that must occur at specific times to achieve client outcomes. So they really focus in on making sure that they are doing exactly what they need to do. They also help patient access community resources, teach them about medication and treatment plans, making sure they get their follow-up appointments, they get their labs, they get their any radiology function, radiology follow-ups and things like that. And so it really is, and I was never a case manager, but it is something that is very time consuming. They do a whole lot. But goal here is cost effective quality care to patients that have complex needs. So when I worked for the insurance company, our case managers worked with like a lot of kids, like a lot of our Down syndrome, cerebral palsy, cystic fibrosis, a lot of the ones that have like those complex illnesses. And then of course, adults that have complex illnesses as well. But it's a lot of work. And this used to only be open to RNs. But I noticed that with some of the care management things are starting to open towards practical nurses now, which I think is awesome. Our client-centered, relationship-centered care philosophy. This is something on client-centered care. The client is always going to be the center of care, but it's providing care that's respectful of and responsive to individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. And when you're doing your admission assessments, and we're doing the cultural assessment, we're doing the spirituality or the religious assessment as well. We're making sure that we're incorporating those into their plan of care. And we're incorporating their preferences and their needs. We're also giving them the information that they need in order to make informed decision making, right? That, again, knowledge is power. The more knowledge they have, the more information, right? The better off they're going to be. So yes, so that is it for chapter 14. So any questions? The goal here is with all of this is knowing that the client is the center of care. But when I was talking about what I thought was really interesting, like I said, with the case management opportunities, I have like 1 minute, but my daughter, my youngest daughter is an LPN. And she started off in she started in long-term care. She liked it, but didn't love it. She got an opportunity to go into OBGYN, which she absolutely loved. And then when she got pregnant with my grandson, She had every intention of going back to work. Like she literally was like, I'm just taking my maternity leave. I'm going back to work. And when she had the baby and she was on maternity leave, she like was like, I don't want to leave the baby, which is understandable. Plus, daycare was crazy expensive. So she started looking at jobs that she could potentially do remotely. Um, and she is a health coach. And so very similar to case management, though not as labor intensive. But she does follow-ups with some of the chronic diseases like hypertension and diabetes, making sure they have their meds or taking their meds, that they're, monitoring themselves. And she's able to do this at home while caring for my grandkids. And that was something that as an LPN, when I was an LPN, that wasn't something that was offered. And even as I became an RN, and worked up, it was something that really just started populating and coming available within probably the last 10 years. So it is something once you have some experience, if that is something that you're looking for. You again, more and more opportunities are opening up for LPNs. So it's kind of like nursing is so diverse. There's so many things that you can do. And even if you didn't want to do traditional nursing, there's other things out there that you can do with that LPN. So just thought I'd throw that out there. All right. Any questions for me, guys? Nope. All right. Well, you guys have a great week. Have a great, safe weekend. I will see you next week. And if you need anything, please feel free to reach out to me. Okay. All right. You guys take care.